Good morning and welcome to the April education session for the Coding Corner. My name is Kristen Robinson. I am a CPC, CPMA, CCC, CRC, and a CEMC. And today's education session is going to be on echocardiography. So just a little bit of my background. I've already went over my background as far as certifications. I'm also with my local chapter for AAPC. I'm the current president this year. I have a background in insurance claim review, medical record review, provider and coder education, as well as an extensive background in cardiovascular, vascular, critical care, and pulmonology. So today's agenda, we are going to talk about what is echocardiography, what is TTE, TEE, stress echoes, TEE guidance, and we're also going to cover some documentation examples. So, what is echocardiography? By definition, echocardiography or echo is a procedure that uses high frequency ultrasound waves to create an image of the heart's structures and function. The primary focus of pediatric echocardiography is the detection of congenital heart defects, evaluation of the basis of cardiac arrhythmias, which are irregular heartbeats, and the detection of acquired heart diseases. Echocardiography may also be used for the evaluation of heart murmurs and the effectiveness of medical therapy and surgical treatments. So, first, we're going to go over transthoracic echocardiography or TTE. This is for non congenital conditions. So, the two main codes that we have for non congenital complete TTE procedures are 93306, which is when all of the required 9 elements are documented with spectral and color Doppler. 93307 is when all 9 elements are documented without spectral or color Doppler. So you may say, if you're not familiar with echocardiography, you may say, what are the required elements? So we have 9 required elements that are on the left side of the screen, as well as 4 that can be documented but are not required to be there to build a full, complete TTE. So the required elements are the left atrium, left ventricle, right ventricle, the aortic valve, mitral valve, and tricuspid valve, as well as the aorta that includes the aortic root, the ascending aorta or descending aorta, and the pericardium. Now, the non-required elements, but you may also see, is the pulmonary artery, the pulmonary vein, the pulmonic valve, and the inferior vena cava. So let's look at the required modalities for 93306. So spectral Doppler may also be documented as continuous wave or CW Doppler or pulsed wave or PW Doppler. Then you have your color flow Doppler. This may also be documented as CFD, color Doppler imaging or CDI, color flow volume or CFV, or color Doppler CD or color flow mapping. Those are all terms you may see documented as either spectral or color flow Doppler. Now, bubble studies. If you all are already coding echocardiography, I'm sure you've seen this before. If you all are new to coding or you're wanting to learn more about echoes and want to understand the bubble study a little bit further, a bubble study is used in conjunction with the echocardiogram. It is not billable separately, and it is simply a saline solution that is administered during the study. Typically, what they're looking for is a PFO or a patent foramen ovale. And what happens is when they inject the saline solution, it bubbles if there is a PFO present. Now, it can be used for possibly other congenital conditions, but typically you're going to see this if they are looking for a PFO. So, a few coding tips for your 93306. It cannot be reported based on whether or not regurgitation is documented in the findings. Spectral Doppler and color Doppler must be documented as modalities in either the procedure description of the report or in the findings, letting us know what was seen by that color Doppler or spectral Doppler. This is an argument I've had with providers for years that they say, well, you can't see the regurgitation if you're not using spectral or color Doppler. But as coders, we are not allowed to make that assumption. We have to go based on documentation, and that's what you need to be educating your providers on. So, if an acronym is not used in conjunction with the word Doppler, or it is not documented in the modality portion of the description of the report, we can also not make that assumption. We need to make sure that the providers are clearly documenting this in the report. If one or more of the 9 elements is documented only in the measurement, it can still be considered a complete echo. So that means that if your provider doesn't give you the like 9th element or the 8th or 9th element, but you can see in the measurements that there is a result for that specific element, you can still count it towards a complete echo. Now, that being said, if the indication, if the report indicates that this was a limited echo, but you find all 9 elements in the report with a appropriate finding, you can still bill a complete echo. Now, on the opposite side, if they document it to be a complete echo, but you are not able to find all of the 9 required elements with findings, then you're going to default back to a limited study, and we're going to go over limited in just a minute. Now, if there was an attempt made to study all 9 structures, but one or more of the structures are not well visualized, as long as your provider is documenting why. Why is it poor imaging? Is it body habitus, or is there some other reason why they were unable to see that structure appropriately? As long as they're telling you why, you can still count it. Also, modifier 26 for the professional component. If you are billing for the professional fee side of things and the provider is doing this in the hospital, almost always the provider does not own the equipment. Therefore, they would only be providing the professional fee component, and you will want to make sure that you're appending the modifier 26. Now, when these are done in the office, if your provider owns the equipment, you can bill the global fee and therefore not have to append the modifier 25. So let's go over some of the add-on codes that can be billed with the complete TTE procedures. So this particular slide encompasses the add-on codes for this code, but you will see a theme throughout this presentation that shows there are many add-on codes that can be billed with all the different types of echo codes. So as we move forward through the presentation, I will not repeat each add-on code. I will then just cover the ones that are different from the previous add-on code slides. So just so you have an FYI on that. So let's get into it. 93356 is for myocardial strain imaging. So remember, again, the modality must be documented. So this may be documented as global longitude strain or longitudinal strain, which is GLS. Typically, you're going to see this finding in the left ventricle. You want to see it documented like in a percentage format, or your doctor should say GLS is abnormal or normal. We still want to see a finding no matter which way they document it. Your 76376 and your 76377. So 76376 is 3D rendering with interpretation and report. This is when the doctor is not telling you that it was done on an independent workstation. Remember, they need to tell you what structure was imaged with the 3D technology and what is the finding from that imaging. For the 76377, this is when your provider documents that it was on an independent workstation. So just make sure that you are reading the report to the fullest extent to make sure which one is the most appropriate to choose based on whether it was on an independent workstation or not. Okay, so we also have 0439T. This is a category 3 code. This is for myocardial contrast perfusion echocardiography. This can be done at rest or at stress and is for the assessment of myocardial ischemia or viability. Remember, they have to be doing this for myocardial ischemia or viability. If done for any other reason, it is not billable, okay? And the reason they do that is we want to be seeing what's going on in that particular area. Okay. So remember that they need to document what kind of contrast is used. Typically, the most common is Definity, but Opticin and Lumicin are also options. And as a reminder, we talked about it earlier for the bubble study. Agitated saline is not a contrast material. If you see agitated saline, that is a bubble study and it is not separately reportable. So here's a quick example of what you would like to see for 3D and for GLS or myocardial strain. So you have 3D volume is 46%. They told you they used 3D imaging, and here is the finding. For the GLS, it is a negative 12.8%. And then they also told you that the global longitudinal strain is abnormal. This is a great example of what you want to see in your report for either 3D or your GLS. Okay, so limited or follow-up TTE procedures for non-congenital conditions. So we only have one primary code for this section. That's your 93308, and this is for a limited TTE. This is when all 9 elements are not studied, and this can be done with or without spectral or color Doppler because this particular code does not inherently include spectral or color Doppler. It can be billed separately. Now, that being said, do not report 93320 with 93308. This is a column 1, column 2 code edit or procedure to procedure edit for those of you that are familiar. There is a limited study that can be billed 93321, which we are getting ready to cover. So with 93321, this is spectral Doppler for a limited study. That's why you see that procedure to procedure edit. That is for complete spectral Doppler. When you are doing a limited report, you want to bill the 93321. We also have 93325 for color Doppler. There is not a complete or limited color Doppler. Either they performed it or they didn't perform it, and the only code to bill would be the 93325. The rest of the codes on this slide we have previously went over, so I'm not going to repeat them again. Next, we have our TTE procedures for congenital cardiac anomalies. So we have 2 primary codes for this section. You have your 93303 when the report is documented as complete, and a 93304 for when it is documented as a limited or follow-up study. So a few coding tips. A congenital ICD-10 code or a Q code must be supported to report a congenital echocardiogram. So if your provider says that they are looking for or they're wanting to rule out a cardiac anomaly, and then they do the echo and a congenital condition is not found, you will default back to your non-congenital echo codes. You cannot bill a cardiac echo or congenital conditions unless you actually have a definitive congenital condition. Now, I put on here the CPT Assistant, December 1997, page 5 and 6, that states codes for congenital echocardiography should not be used when a congenital heart disease is suspected but is not found on echocardiography evaluation. In this case, the non-congenital echocardiography codes should be used. Do not report congenital echocardiography CPT codes when the following diagnoses are only supported. So if you are not familiar with echo coding, um, patent foramen ovalis or PFOs that we mentioned earlier, that's code Q21.12, and bicuspid aortic valve Q23.1 are not considered true cardiac anomalies. These are very, very, very common amongst a lot of people, and therefore they are not seen as true cardiac anomalies. So if one of these two codes or both of these are the only cardiac anomaly codes, you cannot bill a congenital echo. So your add-on codes, we've already mentioned a few of these, so I'm not going to repeat these, but the one that I want to call out on this screen is 93319. So when you have a congenital condition or you're doing a TEE, which we will be getting to shortly, instead of billing your 76376 or 77, you bill 93319 for your echo, or sorry, for your 3D echo imaging. Okay, so make sure you know the distinction between the two when you're billing these services. Also, this code has um, a column one, column two code procedure edit that you cannot bill 93319 with 93325 at the same time. So make sure you keep an eye on that as well. So now we're going to talk about TEEs or transesophageal echocardiography. These are your non-congenital codes. So we have three codes for this section. You have 93312, which is a TEE with probe placement, image acquisition, interpretation, and report. This is your complete global code. This means your provider performed all three required elements. Now, if your provider is only placing the probe, you see this a lot of times in heart surgeries, the anesthesiologist is going to be the one placing the probe and they will document that separately. Or sometimes in your structural heart surgeries, you will see your structural heart doctor doing the surgery and you'll see your cardiologist who is also in the room placing the T probe. So just make sure that you're reading your documentation appropriately and billing it based on what's documented. Your third code is your 93314, which is your TEE. This is your image acquisition, interpretation, and report. So this is only when your provider is just reading and interpreting the report and they are not placing the probe. Okay. So here's a good example of a 93313, also adding your 26 modifier if you're billing the professional fee component. Probe insertion without interpretation. They are telling you in the report, all I did was insert the probe. I did not interpret the report. Therefore, you should know that you cannot bill the full global procedure code in this example. A few coding tips. Remember, just like I mentioned earlier, we need to know who placed the probe. Okay, if anesthesia is the one that's placing that probe, the cardiologist can only bill for the interpretation and report. Also, there are no limited codes for TEEs. Um, so either you get the 93312 for the full global, the 93313 for the probe, or the 93314 for the interpretation and report, period. Okay. Remember, I mentioned a minute ago about the surgeon performing an open chest procedure. Remember that they have to document the interpretation appropriately to get that 93314. Okay, you want to look in the documentation. If the anesthesiologist placed the probe, you need to be looking for that separate TEE report just to ensure that they only build the component that they performed. Okay. So here's another example to look at. This is what we would like to see in your documentation, the provider's documentation. They need to say an adult omniplane probe was inserted by the attending cardiologist. They can say it was inserted by the anesthesiologist or whoever it is. They can name the provider. They don't have to say cardiologist or anesthesiologist. They can say by Dr. such and such. whatever the case may be, just make sure it's documented appropriately. Here are our add-on codes for the TEE procedures. As you can see, we've already went over all of these previously on other slides, so I'm not going to do any particular call outs. Just a quick reminder that, as you can see, you can bill the 93319 with your TEE procedures if it is done during, and I made sure to bold during. If it is done as post-processing, you can bill the 76377. So just make sure you look at the documentation appropriately to see whether it was done during or post-processing. Okay, so now we're going to cover our TEEs for congenital cardiac anomalies. Same type of code set as your non-congenital codes. You have three codes. You have your 93315, which is for the entire global procedure, placing of the probe, image acquisition, and interpretation and report. If the provider only places the probe, that's going to be your 93316, and then your 93317 is going to be your interpretation and report only. Again, there are no limited or complete for these codes. Same guidance as your TTEs for congenital cardiac anomalies. I'm not going to reread this entire slide. It is literally a duplicate of what's required for TTE procedures. There's nothing different. It's a different procedure, but the Q code rule still applies. Again, your add-ons. All of these follow the same rules and guidelines as the other codes that allow add-ons. Okay. So let's talk a little bit about a rule that is very important to follow when you're billing these types of procedures. Per the Medicare NCCI manual guideline, it states TTE and or TEE with a transcatheter aortic or mitral valve replacement procedure. So these are going to be your TAVRs or your MIVRs or MAVRs. If you are familiar with this particular code set, it states transthoracic echocardiography CPT codes 93306 through 93308 and your transesophageal echocardiography codes 93312 through 93314 and Doppler echocardiography codes 93320 through 93325 are not separately reportable by the physician performing the transcatheter aortic valve and mitral valve replacement procedures. And I also have a link down here if you want this link because you're billing these procedures and you don't currently have it, you can always reach out to me directly. So now we're going to cover stress echocardiography codes. Okay, so we have two primary codes for the stress echo portion itself. And then for the stress portion, there are additional codes that can be billed based on the documentation. So 93350 is what you're going to bill for when you're billing components of the code. 93351 is going to be the complete or global code that covers everything. Okay, so 93350 is the interpretation of the stress echo imaging, and then you can bill the additional codes for the portions of the stress that your provider performed. So if they documented the supervision portion of the stress test, you can bill the 93016 with the 93350. You can bill 93018 for the interpretation of the stress test, or the 93017 for the technical component if they own the equipment. Remember, typically in a professional fee setting in the hospital, you're almost never going to get your 93017. You're only going to get your 016 or your 018 or both, depending on documentation. Now, with 93351, this is the interpretation of the stress echo with supervision and interpretation of the stress test. So this is like your all-encompassing code. You also can bill the 93315 when performed in place of service. 11, when your provider owns the equipment. Remember, 93315 is like the complete code that encompasses your 016, 018, and 017 components. Okay. Now, for the 93350 or your 93351, if supervision and interpretation of the stress EKG portion is documented, as well as the echocardiography imaging are performed in a facility, you want to add your modifier 26 to your 93351. Okay. If supervision and interpretation of your stress EKG portion, as well as the echocardiography imaging, are performed in the office, you report the global code. You do not need to add the modifier 26. And again, I will put a caveat if they own their equipment. Now, when reporting in the office, you can report the Q9957 when contrast is used. And code 93351 may be billed in the office or the facility setting if supervision is documented. Just remember that if you're billing it in the hospital setting, you need to use that modifier 26. Here are your add-on codes that are allowed for this particular set of codes. The only call out that's different on this slide is your 93352. This is when they use contrast during the stress echo. You want to make sure you're seeing not only a result of the contrast, what did they see? What are the findings? But they need to be documenting, are they using Definity, Opticin, or Lumicin? There may be others out there, but those are your three most common, with Definity being the most commonly used. The rest of the codes we've went over on previous slides. So now we're going to talk about TEE guidance during structural interventions. So if you're new to coding and you're not familiar, these are going to be typically going to be your structural heart procedures, like your TAVRs, like your MIVRs or MAVRs, those type of procedures. Okay. So remember, we went over the NCCI guideline that told us we can't bill all of those other codes. So when your provider comes to you and says, well, I did this, then you need to know what you can bill. Now, if they are using the TEE for guidance, they can bill the 93355 if and only if they are not the provider that is actually performing the structural heart intervention. If you're in this field of coding, you know that with structural heart interventions, there is typically a CVT or cardiovascular thoracic surgery in the a surgeon in the room, as well as a cardiologist or interventionalist. So your cardiologist or your interventionalist is who's going to bill this code, because the structural heart provider is going to be providing all of the other surgical portions of the procedure. So now let's look at some documentation examples. We're going to be looking at acceptable and unacceptable options. So this is in regards to complete spectral Doppler. So our first one, procedure, transthoracic echocardiogram, complete congenital study, 2D color and spectral Doppler. This is what you're going to want to see in your header, your wish list. There are a lot of things that people call it. This is not all encompassing for the findings you still need to see in the body of the report. This is just what you want your provider to tell you was performed. And then you will corroborate that with the findings within the body of the report. A full comprehensive diagnostic TEE exam was performed with 2D color flow Doppler, PW, and CW Doppler. Number 3, procedure, complete exercise stress echocardiogram was performed, 2D spectral Doppler and color flow Doppler. These are 3 great examples that encompass spectral Doppler. Now, let's look at a couple unacceptable documentation options. So first one, examination, transesophageal echocardiogram with Doppler color flow limited spectral Doppler. They are not giving us all the details. What was completely performed? The second one, diagnostic transesophageal echocardiogram with 3D color and pulsed wave Doppler was performed. Again, they did not give us everything that was done. We need a complete picture so we know what to look for in the findings. Okay, again, some acceptable versus unacceptable options for probe placement. Acceptable. A transesophageal probe 210629E01. That is the type of probe that they use. This is a great example because typically providers don't give you this detail, but it would be nice to see this. This would be best practice. Was inserted by the attending cardiologist. Again, they can say the doctor's name if they prefer, but as long as they're telling you who, cardiologist, anesthesiologist, whatever. Second one, after administration of topical lidocaine, as well as a bite block and induction of sedation, the pharynx and esophagus were intubated with the TEE probe. Great documentation example. Okay, so now let's look at an unacceptable documentation example. The study included 2D imaging, color Doppler, and interpretation. Probe was inserted by other staff. This, in my opinion, is a complete no-go. If you see this, you need to be querying your provider. If you don't have direct access to your providers, then this should not be billable because we don't know who that person was. We don't know if it was our specialty or if it was anesthesiology. We have to have that documented, and I can guarantee you that if this makes it to insurance through a escalated code denial or whatever, they're also going to not pay the provider because it's not complete documentation. So now let's look at a couple documentation examples for 3D 93319 with a TEE. So the first one, left atrial appendage is well visualized and free of any thrombus. It is studied by 3D imaging. They are telling you I used 3D and here's what I saw. For code 76376 with a TTE, left ventricular chamber size is normal. Markedly reduced systolic function is noted. They tell you 3D LVEF, this is the left ventricular ejection fraction, 31%. Aortic valve, the valve is structurally normal. The valve is trileaflet. The leaflets are normal thickness. There is no evidence of vegetation. 3D imaging was performed on the ultrasound machine for a detailed review and assessment of the valve. There is no evidence of stenosis and there is no regurgitation. Great, wonderful best practice example. Okay. Typically, I would open for questions here and then go into examples, but for this particular session, we're going to move straight into examples and we would go over questions at the end of the presentation. So here is a really good example of a limited study. This is where they are looking at the PDA device. Now, for you all that might not be in congenital cardiac, PDA is a patent ductus arteriosus. So let's talk about a little backstory here. So for those of you that are not familiar, a PDA, patent ductus arteriosus, is open during the baby while they're in the womb. And typically, what happens is when the mother gives birth to this child, once they are born, the PDA closes on its own. Best practice. The patient, it closes, no issues. They go on their normal way. But in those instances where the PDA does not close on its own, then a pediatric cardiologist will be involved, and typically they will do continued echoes for the first few days up to the first week or so of that baby's life to see if it closes on its own. If it does not close on its own, they will take the baby to the OR and have a PDA device put in to close the device surgically. Now, there are some times where the PDA is so large that the providers have issues getting it to close even surgically. So that the patient will continue to have echoes done even throughout their entire life to monitor this. So, as you can see, if you drop down to the bottom of the report, you'll see that it says a patent ductus arteriosus is identified. Large, distensible left-sided patent ductus arteriosus. Despite multiple attempts with different sizes of devices, there is still a moderate amount of residual ductal shunt. So this is going to be something, this is going to be worst case of a patient where they're going to have to be monitored very closely to ensure that it doesn't cause other issues within this child. And even throughout adulthood, they're still going to be monitoring this. So our code in this case is going to be a 93304 with our 26 modifier for the professional component. This I had to break up to redact patient information, but let's start from top left and move over to the right. So the procedure performed, transthoracic echocardiogram, 2D, M mode, Doppler, and color Doppler. Indications for chest pain, and then they give you the procedure again in the summary. The study included a complete 2D imaging, M mode, complete spectral Doppler, and color Doppler. And they also tell you the echocardiography images were limited by body habitus, and this was a technically difficult study. So in this case, if any of the 9 required elements they have issues seeing, they've already told you that this was limited due to body habitus. So you can still count that area, but if they don't give you a finding because they told you why. Okay, so on the right side, that all 9 required elements are here. We have our left ventricle, aortic valve, aorta, mitral valve, left atrium, right ventricle, pulmonic valve, tricuspid valve, right atrium. They did include the pulmonic valve is not required. The systemic veins, including your IVC for your inferior vena cava, those 2 are not required. And then you have your pericardium. Okay. So in this particular case, this is a complete non-congenital TTE 93306 with a 26 modifier. Here is an example of a limited TTE procedure. The call out on this particular one is that a bubble study was administered to identify shunting. Like I mentioned earlier, they could be looking for an atrial septal defect, a ventricle septal defect, but most commonly they're looking for a PFO or a patent foramen ovale. So in this case, they're going to get 3 codes. You're going to get your limited Echo 93308 with 26 modifier. You're going to get your limited spectral 93321 and your color flow 93325, all with your 26 modifier. Okay, so that's going to conclude today's presentation. Here are my resources for the education session today. I hope everyone enjoyed today's education session. If you're catching this on the replay on YouTube, please make sure you subscribe and follow the Coding Corner on YouTube. Feel free to jump over to LinkedIn to follow or the Coding Corner on Facebook. I also offer other services if you want to reach out directly. Thank you all for attending for today's session. I hope everyone has a wonderful day.